Good morning, Kalimera. It is my privilege to introduce the next speaker, which is Professor Philippe Camus from Dijon, France. Philippe is considered the guru in drug-induced interstitial lung diseases, and all of us, we know his work on pneumotox. So, Philippe, welcome in Athens. I hope Cleo is here, and you arrived late night, so we look forward to your lecture.
Pneumotox looks like a Greek name, right? Almost. It's a privilege to be invited here. I was my first time here in Athena was back in 1964 as a young kid, and I'm very grateful for this invitation. I'm very grateful, as I will show a little later, that you use pneumotox in Greece and as in other countries, but in Greece particularly. So this is our place, Dijon, France, churches, Dukes of Burgundy, have no conflict of interest, because when you speak ill of drugs, they usually don't give you money to do that. When I was an intern in medicine, a colleague whom I met a few years later, John Stauffer, who is called Jack Stauffer, published a paper, a very interesting paper, numbering or enumerating 120 drugs capable of injuring the lung, and the amount of literature was 770 papers at the time. A very interesting paper. When you look, I'll try to find a pointer here. Yeah. When you look at the amount of literature with the years, you see that it has increased markedly. Is that something that may help?
This and this is a pointer.
This is a pointer?
Yes.
Fantastic. And this is to go to the next slide?
This one.
So this has increased markedly, and really, as you can imagine, it's a daily watch on what appears. Look at these 3 last days. Lupus, 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 unilateral effusion, drug death. This is something we try to avoid with the pneumotox website, allowing you to get quickly to the diagnosis of overdose death, radiation pneumonitis, and a very nice case published yesterday in the New England Journal of Medicine. We opened pneumotox back in 1997, and it has developed ever since. This is a number of reports that help you determine whether there is an association with a drug. And it's now available on the iPhone. You can download it on the iPhone, and it has been submitted yesterday for the Android smartphones. There is a tribute for this development to the European Respiratory Society, and I'm proud to greet the past president and also maybe the future president of the ERS today. This is a map of the people who connect, 110,000 since August 2018. These are the countries, and in white you have the countries which never went on pneumotox, and this is something that worries me because there may be some health inequalities here, and I'm sure the ERS is aware and concerned by this. Now, if we look at the countries, it's a little small, but US, France, And I'll go to, this is US, where people connect from. And this is your country. And so I watch Katarina. How often does she connect to pneumotox? This is Athens, Thessaloniki, and other cities in Greece that you are well aware and more accurately than I do. Let's do a brief journey into what happened since 1960. At that time, the aspirin-induced edema, spasm, eosinophilic pneumonia, radiation injury, exogenous lipoid pneumonia in people who consume paraffin oil for constipation, and the lupus were already known. It's very interesting literature. And interestingly, all these patterns are not old or old-fashioned. They stay with us in the clinics, and we continue seeing. I see people saying, yes. We see this, and the temptation is to say, oh, this is old. You know, that guy from France told us old stuff. But this is still present, especially in the elderly people. Nitrofurantoin, it's the most commonly prescribed drug for urinary infection in women. Most of the affected patients are women. Acute or chronic. Acute is an acute disease in a few days or weeks, mild eosinophilia. If you stop the drug, everything goes well. It's a little bit more complex with the chronic form, which is common, because people will not tell you, oh, doctor, I'm taking nitrofurantoin, because it's largely over the counter, and they don't need a prescription. A series of 18 patients, 17 women, after 2 years on average. It looks like pulmonary fibrosis, not like UIP. There are no honeycombing lesions on the CT. Despite withdrawal and steroids, residual disease was present in approximately half of these cases. This is subacute chronic, and with the withdrawal of the drug, things get better in half the cases. It's still widely prescribed and given even on the internet. It's a big danger for drug-induced lung disease, the internet. For kids, cheap. 1960s, chemotherapy lung with the drugs you know the chemotherapy agents, causing early diffuse alveolar damage or later, for those who survive, pulmonary fibrosis, and it is prevalent in women who receive chemo agent for breast cancer, with always fibrosis, inflammation, sometimes hyaline membranes, or chronic fibrosis, like in this case of mitomycin lung that was given in the urinary bladder. Even topically administered drugs can cause lung disease. If you look at pleural effusion in your practice, please consult with pneumotox. There is a list of approximately, don't remember exactly, 60 or 70 drugs that have been associated with pleural effusion, and stopping the drug will make the patient go better. Some drugs do not give effusion, but lead to pleural thickening. It looks like asbestos sometimes, with pericardial thickening also, and it takes years. It's 4 years between this imaging and that imaging. Well, that imaging and this imaging to clear up. So ergo drugs used for the treatment of migraine can cause this. Drug-induced pulmonary edema, non-cardiac, like a permeability edema, or cardiac. Do you listen? Do you hear me well in the back? Or due to cardiac failure. If you go to pneumotox, you will have a window, number 12, on all drug-induced cardiac problems. And this is particularly frequent with the immune checkpoint inhibitors. It can be very quick. This is a patient examined on CT with radio contrast media, and in 23 seconds, the pulmonary edema had developed. Drugs can cause alveolar hemorrhage, including now the new anticoagulant that are increasingly popular. It's also seen with many other compounds interfering or not with the coagulation. And e-cigarette is a recent addition to the field. Yesterday, case 38 of 2019, 20-year-old man, dyspnea, small, fluffy alveolar opacity suggesting alveolar hemorrhage, and a lung biopsy with hemorrhage clotting in the airways. And this is possibly due to e-cigarette exposure. We had a patient, they produce, and sometimes there are contests, who will do the biggest cloud. And the picture is not, I never change a picture. And this is the actual cloud of smoke or vapor produced by the guy as it was a mystery case in my department. So the nice thing is, you go to your department to visit patients once or twice a week, and the people have fought hard to find a case, and you come into the room and say, hey, what is that stuff? Oh, this is probably vaping-induced lung disease. And they didn't even think of it because we rarely link e-cigarette with lung problems because the reputation of e-cigarettes is, it's harmless. It's not harmless. It's probably not causing cancer, but it's not harmless. This is the cloud, and he has a full arsenal or armamentarium of e-cigarettes. He had a full suitcase full of batteries. And recently a huge amount of vaping-induced lung injury. It's over 2,000 cases now in the US, with 50 deaths, 1 transplant. But it's remitting now. The curve is going down and probably linked to THC or vitamin E. The case is still under investigation. We continue the 1970s with bleo, which is still prevalent and severe lung disease in patients in hematology. Maybe Marc Imbert is with us today. I saw him this morning, but he thought my talk was at 11:30. It's probably the French time, or I don't know exactly. But Marc has been very interested in drug-induced pulmonary hypertension, and the old generation to which I start to belong has been fascinated in the 70s by drug-induced pulmonary hypertension with anorectic agents in young women. This is a partial list because there are 70 and counting drugs causing pulmonary hypertension, including the dazapona and bosutinib, which is the heart of the matters for Marc and his team. Methotrexate, mostly acute, it doesn't produce fibrosis. But beware, it can relapse with rechallenge, causing death. And these are the drugs back in 1973, a robust list of compounds. Imiodaron, now 1,000 papers and counting. Can be mixed with left ventricular failure. BL gives some contribution, but we can discuss it later. It's not absolutely diagnostic. Steroids are often required. It can cause pulmonary fibrosis, and mortality is significant. The drug is still widely used. Foamy macrophages on electron microscopy, foam cells in the lung biopsy, many different patterns, including unilateral involvement, ground glass, boob-like, strictly lobar unilateral, severe cases, especially difficult when imiodaron is given postoperatively, and the disease is confused with infection, pulmonary edema. Sometimes we get to, I saw a dramatic case of an autopsy report. The patient died at 1 month after surgery, thoracic surgery. And the question was, did he receive? And the colleagues told me yes. And did you make an, oh no, we didn't make a link. It's very, very easy to miss the diagnosis. So beware, no amiodarone in a systematic patient after surgery. And if you have to give amiodarone, careful monitoring and corticosteroids may save patients. This is Sir Godfrey Hounsfield, a very, very famous, prominent man to whom we are absolutely indebted because he invented and set up the CT scan from which the machines we use today are derived. You know, a very nice and nice-looking person. And he has left his name to the Hounsfield units. You have here a dense liver and a dense lung in patient with amiodarone pneumonitis. Of course, if you do injected, I mean, contrast-enhanced, you will miss a diagnosis. These are a few other histologic slides. Histology is not necessary in every patient, but if you do so, you will have characteristic features. Amiodarone can produce pulmonary fibrosis. This is pre-amiodarone, post-amiodarone, and usually a poor prognosis. 1980s, drug-induced cough. We all know this with ACE inhibitors, but there are many other compounds that gave, there is evidence for drug-induced cough. So if you have problems with cough, please clean up the prescription, and sometimes the cough will go away. Angioedema with big tongue, compressing the soft palate, arytenoid edema, big tongue. It makes people smile, but it's a terrible disease because it becomes very difficult to intubate. You have sometimes to perform emergent tracheostomy, ending in mortality in some patients. Colored people, especially women, are at risk of developing this condition that can also affect other organs, including the bowel, causing relapsing or remitting bowel pain. This is sometimes tragic, ending in difficult intubation, emergent tracheostomy, and this is a paper about 6 or 8 cases with autopsy specimen of the tongue. So please pay attention. Sometimes people will describe minor episodes, so please pay attention. 1980s, more anaphylaxis, eosinophilic pneumonia, BOOP, and methemoglobinemia, which is an oxidized hemoglobin. Acute eosinophilic pneumonia, it looks like ARDS. And if the patient is intubated, it's very difficult to get a proper history of exposure to drugs. So ask the family, the pharmacy, the general practitioner. We find again the e-cigarette. BOOP, or BOOP-like illness, an acute fibrinous organizing pneumonia also causing relapsing consolidation areas throughout the lung, especially with statins and the immune checkpoint inhibitors. This is a methemoglobinemia problem. Shall I stop? Which is oxidized in Fe tripluses, this poor baby with methemoglobinemia, many compounds, including stuff for the babies when they have their first adult teeth, like benzocaine, can lead to methemoglobinemia. 2000s, anti-TNF, infection, ILD, TKI, drug-induced systemic reactions, including Wegener's-like granulomatosis, sarcoidosis, lupus, and good pasture. Targeted agents, we'll go quickly. If you have any problem, just go to Pneumotox, put your drug, and look at what happens. And if you click here, you have also the bibliography with cavitation, cleaning of the metastatic foci. This is probably bevacizumab, dasatinib. These are the drugs that can cause systemic reactions, including a Wegener's-like with ANCAs, perforation of the ENT area, levamisole mixed with cocaine in many samples. 2010s, DOAC bleeding in the lung, hemorrhage. The drug used in HIV and pleuroparenchymal fibroelastosis that may be associated with some drugs. I go quickly into the immune-related pneumonitis seen with immune checkpoint inhibitors with significant frequency and sometimes leaving or often leaving sequelae. I will leave this presentation where the pneumonitis comes. 0. The risk factors, the clinical presentation that sometimes needs ECMO, imaging. This is a patient we treated recently, was 3 days on the ventilator. Boop, lavage with lymphocyte, but not always. Pathology with boop, diffuse alveolar damage. Beware of the resected lung for those patients who have been exposed in a neoadjuvant fashion because it may show interstitial lung disease. Some variants, unilateral, lobar, cavitation, intralobar fissural thickening, boop-like, acute boop, cavitation, cysts, trin bud, sarcoid-like granulomatosis, can be mixed with cancer progression, a huge differential diagnosis, and not all will improve, some will die from the disease. Street drugs, and I will end with this, can cause acute disease, and people will not always tell you what they have purchased on the internet. This is silicone for those people who are males and want to become with a female shape. Fentanyls, a huge number of deaths in the United States, including synthetic cannabinoids, causing lung disease and coagulation problems. And this is yours truly back in 1963, at a time where I was already collecting pictures and classifying not drugs and, age and years have gone by, and I'm still going, I would say, strong and happy, and very happy to share this topic with a distinguished audience that is in front of me. Merci beaucoup. Evkaristo.
Thank you very much, Philip. Thank you very much for your Greek and for the elegant presentation. Can you give us briefly the diagnostic criteria, how we can be sure that the drug is the cause of these pictures?
If you go to pneumotox, you have a small window in a small widget on the bottom, which is called diagnosing, DIRD. You need to have exposure, documented exposure. The picture has to come after intake of the drug and not before. You have to look whether it is consistent with what pneumotox and the literature say. You look if withdrawal produces an improvement, and look carefully where there are alternative diagnoses. So go to pneumotox and press on diagnosing DRD and follow the 12 lines and checking every aspect of it. Then there is a Naranjo scale that was published in 1980, and the Naranjo scale is very nice to secure your diagnosis. Now, if I propose a diagnosis and Atul looks at the same patient, probably we will not have exactly the same opinion. And also, what matters is, it is certain or it is excluded. in between, it is possible, it is likely, it's fairly likely, as variable percentages in terms of probability. If Atoll tells you it's very likely, then I would vote 90%. If a young student tells you, oh, it's very likely to be methotrexate pneumonitis, you will say 20, 30. Depends who is telling the sentence.
Okay. Is there any question from the audience?
Yes.
Papagiannis.
Where are you from? In Greece?
Thessaloniki.
Here from Thessaloniki. Thank you very much. It's excellent actually to listen to you. I would like to ask from a therapeutic point of view, depending of course on the acuteness of a clinical presentation, are we to introduce steroids sooner rather than later when our patient is visibly deteriorating, even without having an exact diagnosis, even when we risk clouding some other interstitial lung disease or infectious lung disease or whatever? Should we just have our steroid injection in hand when we deal with an acutely ill patient?
That's a very sound and deep and interesting question. When the patient has a severe involvement, look quickly whether this is infection. And if there is a likelihood or probability that it is drug-induced, just remove the drug. And if you have biomarkers like CRP or what else, and you have some time to check, few hours, days, look at how it behaves. Now, if the patient is severe, steroids. But it is at the expense of the quality of the causality assessment. In many papers, I say, oh, I see, we think this is minocycline induced because we stopped the drug and gave steroids and it went better. And the steroids will obscure your diagnosis. So anytime I can, I just stay off steroids, evaluating the patient daily. And if the eosinophils go down, the patient is better, the oxygen requirements are better, then I continue. The exception is amiodarone, because it's sticking. It's very sticky in the lung. It takes 6 to 12 months to go out completely, and even. So I use steroids from the start when my diagnosis is certain enough. Because I saw patients where I said, we will see, and then they went downhill. And I gave steroids, and they continued going downhill, and they died. So I would say early with amiodarone, and a little later than immediately when you can watch the patient for a few days. When the patient is severe, shoot. But the megadose of 1 gram for 3 days have no particular merit compared to 80 milligrams, 80 milligrams methylprednisolone per day.
We have time for another question. Vlasis.
Yes.
He is from Athens.
Last but not least.
You know. Yes.
Thank you very much for your excellent talk. Just a question for your patient after the surgery. He received the amiodarone and he presented the acute lung injury. Do you think that these patients who present with this kind of acute lung involvement are more often patients with pre-existing lung disease? And the second question, maybe this be prevented if the anesthesiologist is told to give the patient low dose of oxygen and low volumes during the surgical procedure?
When a question had self-explanation in it, my father told me, everything is in your question. Number one, try to not use amiodarone when possible. No amiodarone in a systematic fashion after surgery. 2, thoracic and heart surgery exposes the patient to greater risk than abdominal or neurosurgical surgery. 3, low oxygen is absolutely essential. I cannot prove that it will change something. But you know, once you get 92% saturation, If you go higher in terms of PO2, it's just giving more oxygen radicals. Low volumes, because barotrauma is important. In the prevention, I would not give steroids, because steroids will expose the patient to infectious complications. So it might work, but at the expense of risks and infection, and also healing problems on the scar. I'm very proud and honored, really, and happy to have received this invitation and to share. You know, I'm not important, the topic is important. To share this information with you and to know that pneumotox is your companion in your smartphones, in your daily practice. The smartphone was designed to be closer to your patient. It's also working in the airplane mode, so you can work with it despite the fact that you are out of any possible network. So, and thanks for the people who have funded this.
Thank you very much, Philip. Come again. Open invitation.